Hi guys, today we are going through the pediatric surgery R2 conditions. So there are five of them. The first three are the main ones, and then the last two I'll just go over quite briefly. But the first three are the ones you probably need to know a bit more about. So first we'll start with malrotation and volvulus. So what is it? So malrotation is a congenital condition where the bowels don't form and rotate properly in the abdominal cavity, and that results in volvulus, which is the twisting of the bowel on itself, and that can lead to a loss of blood supply in the bowels. So in terms of malrotation and volvulus, 80% of these present within the first few weeks of life, and the most important things to note are the symptoms. So bilious vomiting is normally the initial symptom. And then when you're revising for like PEDS abdominal pain, just remember that bilious vomiting is obstruction until proven otherwise. And then other symptoms include inconsolable crying, cool peripheries, and then other things to note would be the investigation of choice. So the gold standard is an upper GI contrast study, and that will show a corkscrew sign, which you can see on the right side there. Um, and then, yeah, it can lead to shock as well. So I guess the ones highlighted are the main things to note. And then investigation would be, as I said before, the upper GI contrast study. And then in terms of management, so it is most likely going to be a surgical management. So something called the LADS procedure, which basically just helps to untwist the bowels, but you don't have to go too much into detail into what the procedure is. However, say in an OSCE or your apex is now, the things you'd have to note for management would be to make sure that they're nil by mouth. You insert an NG tube and then give IV fluids, IV antibiotics, monitor urine output, and then also do a septic screen as well. Yeah, so that's malrotation and volvulus. And then for Hirschsprung's disease, so it's a congenital condition where the ganglion cells in the lower part of the bowel don't form properly, and that helps with opening bowels. So in terms of the symptoms and the signs, so the main ones would be failure to pass meconium within the first 24 to 48 hours of life. They've got a swollen tummy, vomiting, temperature, and then something called the squirt sign, which is quite indicative of Hirschsprung's disease, which is the explosive release of stool and gas after a rectal examination. And males are more often get it over females. So I think there's a 4-to-1 ratio, and then other risk factors include Down syndrome if they're preterm or if they have cystic fibrosis as well. In terms of investigations, so the rectal biopsy is the gold standard. So it actually looks at the rectum and identifies if there are any nerve cells present or not. But other investigations and imaging you can do include an abdominal X-ray, and that may or may not show an obstruction. And then you can also do a contrast enema to have a look at the bowels. And the treatment of it, so firstly, you'd want to do a bowel washout, and then the more sort of long-term treatment would be firstly a stoma formation. So the stoma would mean that you're removing parts of the bowel that's affected, and then you attach the bowel like to a stoma. And that's a temporary thing that you do, and you wait for that to heal. And after that's healed, you do the surgery, which is the pull-through procedure, and that basically reconnects the bowel again to the rectum. So there are different types. So like the diagram here shows the Swinson procedure, but I don't think you need to go too much into detail about what it is, but just an overview of the treatment, which is the pull-through procedure. All right, and then next we have the inguino-scrotal swellings. So this is like a broad category of a few conditions. Um, I think the main ones you would need to know for the exam would be testicular torsion, torsion of the appendage, and epididymo-orchitis. And this is a good table that I found that helps to summarize the three conditions. So looking at the testicular torsion first, um, so in terms of a history, it's going to be an abrupt onset of severe testicular lower abdominal pain. Often because it's so severe, there's going to be nausea and vomiting. And there might be changes in their gait because of the pain as well. And then risk factors include neonates or teens in their pubertal ages, and if they've had a previous torsion, family history, or a bell clapper deformity, which is where the testicle is not attached to the scrotum, and that basically increases your risk of having a torsion. Um, and then examination findings. So um, it would most likely present with a swollen, tender, painful, swollen testis. Um, and then, as I said before, a wide base gait, and then something called the cremasteric reflex, which is usually absent. So what the reflex is that if you stroke the medial thigh, it elevates the testis. So in this case, it would be absent. Um, and then something called the negative Pren sign. So if you elevate the hemiscrotum, it will exacerbate the pain, and that's considered a negative sign. And that's different from the positive Pren sign, which helps to relieve pain, which we'll go into later for the other conditions. Um, and then investigations. So you can do a Doppler ultrasound, but if you're quite certain it's a testicular torsion, then you shouldn't be doing it if it's going to delay surgery. And so, because it's a medical emergency, the treatment for it is a detorsion within 6 hours. So, an urgent surgical exploration, you'd be admitting them under gen surge and then giving them nil by mouth, cannula, and pain relief. So, next up is the torsion of the appendage. So, what that is a twisting of the small piece of tissue attached to the testicle, and that causes localized sharp pain. I like to think of it as like appendicitis, but for the testis. So there's something called the blue dot sign, which is like a physical examination sign. So you might see a small bluish dot on the overlying skin of the testis, and it's more common in prepubertal males. The treatment of it is mostly supportive. You counsel them that the pain will resolve in about 2 to 10 days. But if you're not sure of the diagnosis, then it may require surgical exploration. And then finally is epididymo-orchitis, which is an inflammation of the epididymis and testis. So the key history here to differentiate between the two is that the pain is more a gradual, sudden onset. Sorry, not sudden, it's a gradual onset. And yeah, usually unilateral as well. And then you might have some urinary symptoms, so dysuria, increased frequency, any urethral discharge, suprapubic pain. And then with the physical examination, in this case, you'll have a positive Pren sign, which when you elevate the hemiscrotum, it will relieve pain. And the cremasteric reflex is intact. So in terms of what causes it, it's usually a bacterial or an STI. So if you suspect it, you'd be doing a urine MCS or urine chlamydia and gonorrhea PCR if you're suspecting if it's an STI cause. And treatment of it would be antibiotics, either oral or IV, depending on severity and if they can tolerate. And then I guess for reassurance and counseling, just letting them know that it's quite slow to resolve and that there might be ongoing swelling and discomfort for a few weeks. So these are some tables that are quite helpful. Some of them I got from the RCH guidelines and the others from RACGP. So if you have a look at them, they help to differentiate between the different types of groin swelling. Okay, so moving on to undescended testis. So what it is in a normal situation, the testis would be situated in the scrotum and it travels down through the inguinal canal. But if it's undescended, that means the testis is located in the groin or the abdomen, so pretty much anywhere between the abdomen, the inguinal canal, and then into the scrotum. And it can be congenital or acquired. Diagnosis is mostly through physical examination, and imaging is not routinely required. So if it's congenital, they might only require observation for 3 months because it can descend on its own. But if it doesn't descend after about 6 months, then you would do surgery, which is something called the orchidopexy. And then finally, we have hypospadias. So what that is when the urethral meatus is not at the tip of the penis. and that can cause abnormal curvature of the penis and underdeveloped foreskin. And on the right there, there's, I guess, different types of hypospadias, and that shows where the urine can come out from. In terms of signs and symptoms, so something called a chordee, which is basically just a bend in the shape of the penis. There might not be a straight stream of urine. The foreskin might be a bit hooded, and then you might notice that the opening of the meatus is not at the tip of the penis. And then treatment is pretty much always surgical unless it's very mild. And the age of surgery, you do it between 6 to 18 months. I think that's pretty much all you need to know for this condition, really. Yeah, so I think the main ones would be the first three conditions that we talked about. Yeah, so hopefully this is helpful. And if you have any questions, just let me know. Thank you.